And so you can see that this is titled just a tiny bit differently than what we put in the agenda. And I did that purposely. I think that, the title for the agenda is fine, but I want to use this platform by which to anchor my presentation. And I'll briefly tell you the story behind this. For a few years now, I've been directing a CTSA work group focused on the inclusion of older adults in clinical and translational research. And so that group is addressing the challenge that older adults historically have been underrepresented and sometimes seriously underrepresented in clinical trials of the treatments for which they will become the majority consumers. And so our group as a whole is dedicated to doing what we can to address that problem. Certainly helped a lot by changes in NIH policy over the last couple of years, which, for example, now any exclusion of older adults in research has to be specifically justified. We have developed as part of our work group a whole set of modules trying to provide guidance and as well as to advocate for the inclusion of older adults. And so one of those challenges that I frequently encounter is that people may feel that including older adults in clinical and translational research just complicates things from a study design or a statistical point of view, to the point that they worry that they will lose validity for their study if older adults are included. And so that was the purpose of this presentation, to really provide some guidance on identifying common statistical issues, but giving at least a thumbnail sketch of how many of these can be addressed. And so I'm going to go through this. One thing that you already see is that this is really statistical issues related to clinical and translational research with older adults as a specialty topic. I hope that we'll make it interactive though. Don't hesitate to unmic and dive in. Don't hesitate to use your hand raise function. I really welcome your thoughts, both in terms of communication, but also if you feel that I have missed a big ticket item, please raise it, because it's absolutely something that these slides can still be improved as they're just about to be posted on the national CTSA website. So I think we first should pause, and just consider, do older adults seriously complicate study analysis and interpretation? There's a common wisdom out there that older adults only selectively participate in studies, so missing data issues are terrible, that older adults' data are messy somehow, not as well measured perhaps as others, and that their heterogeneous health status and complex health status complicates study interpretation. And I can't, I would be lying to say that none of this goes on. But my own feeling is that sometimes these issues are overblown, at least relative to similar issues that also occur in younger participants. Besides that, older adult inclusion, I would claim, has real benefits to study analysis and interpretation. It's not just a litany of downsides. The first one is at the very top, that there's an imperative that older adults must be included if studies are to validly estimate the efficacy and safety of treatments in the market where those treatments will predominate. There's just not a question. And so from this point of view, it really has to be done. But above and beyond that, older adults turn out to be dedicated study participants. This common wisdom that, somehow they are less robust study participants has a lot of flaws to it. Older adults experience heightened event rates. That actually may enhance study power in a variety of studies. I really hold by the third one there in that block, that addressing complexities challenging interpretation in older adults actually provides a roadmap for addressing those very same complexity as in other participants. Very frequently it's not as exclusively older adults or even predominantly as I think some people will argue. And then finally, clearly understanding mechanisms in older adults as a point of the spear. I have to credit Linda Fried for that phrase. Seeing aging as a point of the spear for adverse outcomes may provide general mechanistic insights. And I'm going to talk more about that in a minute. And in fact, I'm going to go ahead and talk about that now, just to give you an idea where I'm coming from. And so this idea of the point of the spear is that by the time we've arrived in late life, over to the right here, lots of things often are manifesting in terms of health problems. And so we catch older adults often as they've already experienced harms of various kinds, whether it be multimorbidity or disability, cognitive dysfunction, some of the other things you've seen here. But these things haven't arisen out of nowhere. Rather, frequently in midlife, there already have been risk factors that portend what will happen in later life. And so the idea here is that what if we were to take these outcomes in late life and follow them backwards to identify, what the midlife risk factors or preclinical states or alterations in stress response may have been. This can provide us with clues to general mechanism that we then might be able to track even farther back in life to early life behaviors or stressors or family factors or even genetic determinants. And, I'll just give a plug for the ERIC study. Richie Sherrod is here with us. And the ERIC study, for example, provides a wonderful opportunity to evaluate at least the midlife to late life part of this spectrum. Okay, so for the rest of this talk, I want to provide just a sampling of the highest profile challenges and opportunities to address older adult inclusion in studies by thoughtful study design or application of statistical methods. You'll see that my coming slides all have a certain design to them where a challenge is identified and then 3 different strategies to addressing it is laid out. Pilot studies, which inform study design, and then finally data analytics strategies. And we'll conclude with some take-home messages, challenges or gaps, but please weigh in if you have additional thoughts at any point. Okay, so first one, I imagine is not a surprise to anyone, which is selective participation and particularly dropout in studies. The idea that if older adults participate, perhaps it's the healthier individuals who may be participating, and dropout may occur as health worsens and or the study is just too intensive. We well know the threats that arise from this, and that is the threat of misrepresenting the intended population because of sample loss, let alone just losing sample size and implications of that for power and precision. One anecdote I always think of along these lines, we've been doing multiple cohort studies for decades here out of the Center on Aging and Health. And one thing that we have tended to see is that the incidence of frailty is not always nearly as large as we would expect it to be as people age through these studies. And so is there honestly negligible frailty incidence as people age? No, it's probably that people are dropping out as they become frail. An opportunity, of course, is that younger participants drop out as well for all kinds of reasons. And so solutions will generalize to younger participants. Pilot studies provide us an opportunity to perform interviews, qualitative research, to learn about barriers to participation, potential solutions, whereby participants might be retained in studies, home visits, that sort of thing. Study design really, as you know, is far better than trying to fix things statistically. So, at the very least, a sample size inflation to account for incomplete recruitment and attention, but innovations to reduce barriers. I think the last two may be underutilized. The first is something that we're doing in the spring study, and the Salisbury eye evaluation also use this to good effect, what I call a foot in the door questionnaire. So, as a person is just on the verge of declining to participate in your study, or they're telling you, look, I'm just not going to participate anymore. Sometimes they will be willing to fill out a very brief exit questionnaire, which ideally should be focused on outcomes, key outcomes for the study. Knowledge of these outcomes then allows us to estimate the usually non-observable factors affecting missingness, and hopefully to, at least in sensitivity analyses, try to implement a correction. Auxiliary data is also a great way to learn more about who it is who is dropping out or selectively participating. The ERIC study has done this to great effect, the ERIC NCS study. And then analytic strategies. I've listed 3 specifics there for the more statistically oriented people: inverse probability weighting, selection modeling is a particular missing data analysis technique, and then sensitivity analyses, basically aimed at estimating how large a dropout bias would have to be to overturn a result. All of these, in some ways, aim to provide a crosswalk between the data we observed and the intended population. And 2 very quick schematics. If we imagine that along the x-axis is the number of diseases, the y-axis is increasing polypharmacy, and then the area of the circle is proportional to the percentage successfully recruited, or maybe a little bit more cynically, included in the study at all. Then what something like inverse probability weighting would do would be to essentially count each group, to overcount proportional to the underrepresentation in the study. Let me pause and see if there's any questions about that. Okay, and so then just a twist on sort of the same topic, rather than flat out participation or not, dropout or not, sometimes there's partial participation, right? And so somebody remains in the study, but we miss measures on them for whatever reason. We're actually encountering this in our study of resilience quite a bit, and that, for example, it proves difficult to obtain the oral glucose tolerance test. And that's not just random. It's often, people with various health status issues for whom we don't obtain those measures. And so similarly in pilot studies, working with coordinators to find out why selective measures are being lost. Design, we can do things like prioritizing key measures early in the assessment. Record reasons for data missingness is absolutely crucial, because often the reason is informative. And then there are data analysis strategies. Most of you will have heard of multiple imputation. There's a lovely result that, at least for data that are missing at random, meaning that data are not, that the missingness is not associated with unobservable factors after accounting for factors that are observed. If that's the sort of missingness that one has, then maximum likelihood provides a valid method to analyze data, even absent multiple imputation. And very importantly, distinguishing couldn't perform a task, couldn't complete a cognitive test, versus randomly didn't. Okay, and so I want to take a moment just to let you put a few challenges in the chat, and I can tell you whether we're coming to them or not. I have 4 more. if you had to name extra challenges in the study of older adults, what would you identify? Go ahead and put stuff in the chat. Measurement error, cool. That one's coming. So cognitive impairment is something very specific. Competing risks, that's a great one. And so that's coming. So more of a, statistical or epi rubric of challenges. Okay, well, that's good for a start, and you can be thinking potentially of others. The next one I have is competing risks. And so, clearly in study of older adults, particularly oldest old adults, we do have to, be mindful that death may frequently compete with the ability to observe some other outcome, and that just ignoring this phenomenon can lead to flawed and misleading interpretation of study findings. And so, there's an anecdote where one can talk through the fact that at least there was some appearance early on. Some were claiming that hydroxychloroquine was an effective treatment for COVID. And, so you could make up a story whereby, it may look like, among those whose data you observe fully, that, those on hydroxychloroquine may have done a little bit better than those on not. When in fact, hydroxychloroquine may have been strongly associated with death rather than progression to severe disease. And so by ignoring the death outcome, one ends up with a completely misleading overall assessment of the value of a treatment. And so what are opportunities? Well, by addressing competing risks, we can make a much richer delineation of treatment or exposure impacts than by ignoring them. It forces us to evaluate the entire landscape of potentially adverse outcomes. In pilot studies, for sure, one should document and prepare for a certain proportion of death that may occur predominantly in older adults. That has implications for study design, also may have implications for how frequently we schedule measurements so that we obtain, to a reasonable degree, as much information as we can before people then may be lost to the study. And then what are analytic strategies? Well, all the strategies aim to explicitly account for competition by in some way addressing all of the risks. Composite outcomes can be a very valid way, I would say not always, but can be a valid way to address this issue. So in COVID studies, we frequently have seen progression to severe disease or death as a composite outcome that sometimes is a very useful composite outcome. And then there are various competing risks specific methods of analysis. It's important to recognize that there's not just a method for competing risks. There's quite distinct methods that in different ways attempt to address competing risks. The cause-specific relative hazard can be implemented using the regular Cox model, so that's convenient about it. The subdistribution analysis is a method for evaluating cumulative incidence of an outcome, where people who die are just recognized as never having the incidence of that outcome. And then latent variable methods attempt to infer the counterfactual, essentially, what might have happened if the competing risk hadn't occurred. And all of these can be useful in various settings, but just justifying the relevance of a given method to one specific goal would be the important thing to do. Doing this just to keep track of the time. I see something in the chat. Okay. Oscar, do you want to say something more about what you've put in the chat?
Hi, Dr. Bandeen-Roche. Just because you asked about challenges, I just remember that we tried to do a study based on a census in a community, and we went to the places to do the measurements, and one of the challenges was to do the bioimpedance analysis, because we required to participants to lie down for physical reasons first, and also for the location that was low-income place city homes was not possible. So even if they accept in your sample is more healthy population, that the real prevalence of sarcopenia or other measure.
Absolutely. I love that example, for highlighting sometimes the need to be, very thoughtful and creative about how to include the full range of older adults, and indeed all study participants, according to the wherewithal to participate in a potentially intensive study. And there's all sorts of creative design things one can do. One might randomize people, for example, to have this high-tech assessment versus not, and then that creates information by which to correct biases for people, who for whatever reason either decide not to or can't participate. Thank you.
Thank you.
Okay, the next one is measurement, and well, definitely I hope that others will weigh in, because there's others who focus on measurement issues at least as much as I do. Measurement can be difficult in older adults. So there's a talk I give where, one of the examples I raise, that even something as unambiguous and commonly measured as blood pressure, needs to be measured particularly carefully. The cuff size, if you use a standard cuff, it may not be tight enough to even measure the blood pressure appropriately. There's postural issues, orthostatic issues, where the blood pressure may differ quite a lot from a sitting or lying down to a standing setting. So there absolutely can be increased variability. There are more serious threats, such as conflating the intended outcome with the measurement modality. So when there is differential measurement, we have an example where it appears that systematically different racial groups differentially interpret questions on exhaustion. And if this is true, you wouldn't be able to tell whether there's a racial difference in the prevalence of exhaustion in older adults, or it's just that the measurements differ. And so in either of those cases, inferences can either be unnecessarily imprecise or even invalid. And another example you can see there is with cognitive testing and sensory impairment. There are many cognitive tests require one to be able to see, letters and numbers and such, or to be able to hear instructions. And so it can be really difficult to tell in persons with sensory impairment whether there's a cognitive impairment or it was just a sensory impairment. Opportunities out there, again, there's those of you on the thread who could really speak to this better than I can, but we have access in the last 10, 20 years to technologies, that allow for probably a much more representative measurement, not only because it's objective, but it can measure people in their real life. Through wearable devices like accelerometers, sensors, implantable devices. Jen, or I don't know if Jacek is on. Either one of you want to elaborate on that?
I mean, I don't know, like in what regards, like the great potential for measurement error, or?
No, the potential for wearables and such to improve measurement.
Okay, yeah. Well, the idea being that these types of devices give us a much better idea about how much someone actually moves, right? So in that regard, we're taking all movement, right, which is physical activity is movement above resting, versus just asking people, right, on a questionnaire, like how much do you do, which is almost impossible for people to recall. Is that?
Yeah, no,
Okay.
that's good. Just wanted to give you an opportunity. So
Okay. Sure.
yeah. Pilot studies, those of you who've taken the STAT for psychosocial research might recognize the multi-trait, multi-method study. This can be a way to, with a relatively small amount of data, to understand whether measurements are behaving in the way that one hypothesizes they should, at least to an extent to carry them forward into a larger study. That method, all that it requires is a correlation matrix, and yet structured in a certain way can be very helpful in terms of understanding measurement properties. Design anchors refers to methods of measurement or questionnaire items, that are thought to be invariant in their performance in measuring what is intended across subgroups of people or across time, and so being sure to include some measures that have been well studied and are thought to be invariant is a important thing to try to do, as well as thoughtful tailoring of measures to and across subpopulations. And so then what can analysis do? Analysis aims to faithfully characterize the target of measurement, by by bridging measurement differences. And so you can see some specific methods for either exploring or addressing error ramifications. So the bottom two, so the middle two there, error calibration, modeling the variance in terms of the mean, are ways to address measurement errors. The second one is sometimes called errors in variables analysis. If it's thought that the problem is just non-differential measurement error, it's not so much something that's imposing an spurious systematic difference. For sure, we do see heteroskedasticity where the variance may increase with the mean. Lab measurements are notorious for this. There's methods of dealing with that. Alden has done a tremendous amount of work on harmonization. Do you want to weigh in and say anything about that?
Yeah, I would say, broadly speaking, when you're doing harmonization, either with latent variables or with other things, and it's very important to clearly specify what's your target attribute or thing you're seeking to measure. Like, do you want to measure cognitive functioning? Okay. Do you want to measure executive functioning or memory? What does executive functioning mean to you? And this is something that you want to clarify and specify no matter what your project, but it becomes very important, especially when you're seeking to combine different measures in ways that to create something new that you want to be common across different sources.
Thank you, Alden. And so these methods typically will use a statistical model to try to, in a sense, filter out differences, systematic differences between different measures in measuring the same underlying construct, hence the importance of what Alden just said. And then functional data analysis is a set of statistical methods for dealing with highly data intensive streams, such as one would get from accelerometry measured, every 30 seconds for a week long, or those sorts of things. And honestly, aging has spurred some of the statistical advances, the really important statistical advances in that field. Okay, the last two, I think were not as obvious, but see what you think of these. So we hear this a lot, that older adults will come with a bunch of concomitant diseases that they have, or they're taking a bunch of drugs, and so they will make my study impossible to interpret. And certainly those complexities do, they have to be considered thoughtfully because they do have the potential to alter treatment mechanisms or, to engender subgroup effects. But certainly not a reason to exclude these individuals, given that frequently they'll be the majority consumers of the drug or the treatment when by and by comes, to fruition. And so rather than just excluding individuals, to study these phenomenon have potential to yet lend insights regarding mechanisms of how a treatment may work. They create actually more heterogeneity among individuals, which actually can create statistical leverage. Those of you who've taken a year of statistics have encountered that term. Basically spreads people out in a way that can actually add power for detecting relationships. And so in pilot studies, clearly a place for very thorough literature review to get on top of what some altered mechanisms might be. This is a great arena for secondary data analyses using existing cohorts, for example. The aging field is very fortunate to have these, a great resource of cohort studies by which to identify potentially key areas where heterogeneity or effect modification may be strongly at play. Design then, should account for the potential need for considerations by strata. In causal inference, adaptive and subgroup designs is an extremely active area of research, and we have real strength of that in our Department of Biostatistics. Identification of variables where strengths can be borrowed. And so I try to think of an anecdote to explain what I mean. If we're interested in effectiveness of flu vaccines in older adults, how effective are they at preventing the flu? We know that we can suspect that, they may not be as effective in sicker individuals, and feel overwhelmed by all the different ways in which people can have multimorbidity. But, it could well be that the real mechanism has to do with pro-inflammatory states or altered immune status. And so then that's a reduced set of variables to measure rather than the whole constellation of multimorbidity that could occur. And then finally, what does analysis do? Well, first, reduce noise due to heterogeneity, as well as to leverage heterogeneity to learn about mechanism. I think it's underappreciated that baseline covariates can be adjusted for validly in trials and have the potential to gain substantial precision if done in an appropriate way. There are causal methods by which ones can try to reduce a highly dimensional set of covariates into a much smaller one. That's propensity scores is a key example. Other analyses that can be performed. There's advanced model selection techniques to identify key effect modifiers without overfitting the data. And then finally, mixture models to attempt to identify potentially subpopulations with systematically different treatment response. So some really cool methods there that can be brought to play. This is the last one that I have. And so this is coming back to this idea of leveraging older age as the point of the spear, which I hope I've already motivated has the opportunity to lend insights into either treatment mechanisms or health mechanisms. Pilot studies, certainly is an opportunity to hone protocols to make design elements practical, meaning that we include at the broadest range of older adults that we possibly can. And one way to do that is by avoiding overburdening the protocol so that individuals have an opportunity to participate. One super important design element is to be sure to include gerontological outcomes because these outcomes tend to be synthetic, measures of older adult health, you know, that really have potential to ground analyses that can then identify risk factors earlier in life in a way that is meaningful. These are geriatric vital signs. What do I really mean by this? Well, I mean measures of physical function, performance, walking speed, grip strength, measures of cognition, frailty, sarcopenia in older adults, falls, these sorts of things. And then probably goes without saying, but to measure outcomes repeatedly, because trajectories or trends give us an opportunity to possibly infer earlier to mechanistic causes. And so then analysis, effect modification by age often, you know, does have the potential to lend insight into mechanisms, you know, by which treatments may gain or lose effectiveness. Backward time analyses may be underutilized. They're utilized to great effect in studies on cognition with, you know, for example, the onset of dementia being an index time, and then using that essentially as an anchor by which to conduct analyses predicting determinants backwards can be a very valid way to go about things. Trajectory transition analyses, and then in the spring study, we are implementing biomathematical models known as dynamical systems analyses, where we literally are attempting to model mechanisms by collecting physiological data in multiple dimensions and evaluating how the relationships among these different physiological mechanisms, importantly, how they change and may rebound back in response to stressors, then has utility for predicting longer term outcomes. So let me pause there and see if there's any questions either on that or the previous item. So that brings me actually to the end. And so, oh, sorry about that. Hopefully I don't need to give this exhortation to all of you to engage statisticians and epidemiologists, but just a warning that as we've been going around to clinicians and clinical meetings, we've been giving them this exhortation. We've been telling them, engage us, because we love contributing to thinking about strategies for problems like these. To keep in mind that it's not all bad, you know, that including older adults robustly has the potential to add insights, solutions generalized to younger participants, and complexities, you know, sometimes are overblown, that studies of younger participants experience these same complexities, many of them too. And finally, that there's a lot of good. Older adults really are dedicated study participants. Added heterogeneity can be leveraged, and aging can be thought of as a point of the spear that can generate insights about determinants earlier in the lifespan. So let me pull down my slides and just see if there are any thoughts, very much including now, you know, did I miss something big? You know, something you think that, you know, I should have named as a big ticket challenge and I didn't? If not,
You know, I think that it was an undercurrent throughout, but an important, I'd volunteer an important thing to always consider in your questions is time. Like, not just whether you're interested in modeling trajectories or rates of change, that's super important. But if you're going to look at like an exposure and outcome, how far away do they need to be in time, or do they need to be far away in time? You know, this is worth thinking about. Do you need to conduct sensitivity analyses in order to get your study more in line with your causal thinking around time?
I like that one, Alden. And, you know, I do often find that the timing of, you know, say a set of determinants and outcomes is either confusingly delineated or, you know, as you've just pointed out, not thought through in terms of the optimal, how long does it really take in order to observe an effect, and is the study appropriately designed for that lag? Thank you.
I'm just going to second that, or I guess third that. Especially, in studies that go on and on forever. You don't need to use all the on and on forever data. You have an opportunity to actually be very selective in the follow-up that makes sense, and maybe even begin to ask questions about what is the most sensible follow-up for given age groups or given questions.
Absolutely. And then with the, converse benefit of enhancing retention and adherence, if you actually make a study a finite length that people can hang out with. I like that.
Well, and adding to what Eleanor said, another really important thing is how changes in technology affect these studies that go on and on forever. Whether it's a change in the sensitivity of an assay or the change in a device like physical activity, it can be extremely hard to do a really long-term analysis. Even though you have it, the data is so misaligned in some ways that it's really difficult to actually make it happen.
Absolutely. And then that dovetails with the measurement issues, right? That becomes an area where harmonization may be necessary because of an evolving measurement form or technology, or, and I do want to say, I don't want to pretend that analysis can fix everything. If it can be fixed by design, that's better, but hopefully analysis can help.
I'll add, I think that's a great point about technology and even any changes in questionnaires that are technologically thinking they're advanced. It is a challenge for us. But I wanted to go back to time. I think time really suffuses Jen's point and Alden's point. And I'd add to that something that you said, Dr. Bandeen-Roche, that actually sets us up for our upcoming seminar presentations. Alden and I are going to be talking about cognition. So you really set us up to really riff off of some of the points you've made, that we can provide examples from the cognitive aging literature. And of course, Alden is an expert in measurement. But one thing that I wanted to mention here that I think you've inferred through a number of your comments is this idea of dynamic measurement, that we're measuring in static terms something that is dynamic. And then it's dynamic not only within itself, but amongst other physiologic measures. You made a point about your plans, which are extraordinarily exciting, to look at different physiologic systems. But even within one system, just recognizing that these systems are dynamic. So if I measure you in the morning and I measure you in the afternoon, I'm guaranteed to get a systematically different response. If I measure you on caffeine versus off caffeine, I'm guaranteed to see, and I can predict what's going to happen. So these are things that we know about, even just cognition or speed of processing, depending on what measure we use, but we don't incorporate those into our thinking. But we should think about, like you said, some of the things you mentioned are going to come back to us when Alden and I speak in the next sessions. Repeated measurement can be highly valuable. When we don't know, when heterogeneity occurs with underlying unmeasured or latent factors or variables accounting for it, sometimes we don't know what those latent factors are. But if we conduct repeated measures, we are probably better able to increase the signal to the noise ratio. So I think we'll be talking a little bit, and you've set us up really beautifully for those kinds of discussions for our subsequent presentation. If Alden, I think that's right.
Michelle, yeah. Thank you. Yeah, absolutely. And, I love how you highlighted, the influence of, factors we sometimes don't think about on measures, and maybe the need to collect some of those. So I am mindful of the time, and, I'm happy to hang out if anybody wants to have further discussion. I want to absolutely give people, who need to go, feel free to go, try to end on time here. And I'm not saying there should be any further discussion, but please feel free to get off if you'd like to. Let me just see if anybody else had wanted to raise anything more before we close the session entirely.
Hi, Karen. I just wonder if you can elaborate more on the approach analyze the dynamic systems.
Yeah, I mean, so, I think Michelle really elucidated the idea is that we are studying dynamic constructs. Aging is all about development and change and, sometimes decline. And so, if one is going to understand the, mechanisms underlying a system, in a system that is dynamic, then we can really only do that by stimulating the system and evaluating how it changes. And so, the dynamical systems models are ones in which we actually perform a stimulus, so we bring people into our study and we give them a stimulus and then we collect a time series measuring what the response is. And so, for example, in an oral glucose tolerance test, you give somebody a swig of a big sugary drink and then you measure glucose and insulin and other things. And you watch how they increase in response to the drink and then hopefully, come back to the steady state level. And so one can model that process, the rate of increase, the rate of return to normal, using mathematical equations. And so that's what we're trying to do. We're trying to use what ideally would be differential equations to model those stressors. And we'll see, whether the parameters that approximate the mechanisms that govern those systems end up being useful summaries or lenses into etiology, or they don't. But, it's very exciting to be part of a study that's at least trying to do it.
Yeah, absolutely. Thank you.
All right, well, why don't we go ahead and close out the session. It's been really good to see everyone, and we'll look forward to seeing you 2 weeks from now. Take care, everybody.
Bye, everyone. Thank you, Karen.